Okay, Terry.
Terrific. Well, welcome everyone. This is we're meeting now every other month with the coalition. So much is happening in telehealth. And today, besides our usual update and reports, we're really going to focus in on what we're seeing out there in terms of the quality and the impact of telehealth. And we have a very distinguished panel with us today. And we're hoping that you folks will also feel free to jump in and make comments. Feel free to do that either in the chat box or just if you got a question, just unmute your line and ask us. We'll keep it relatively informal. But this is the agenda. We're going to start off. As I indicated, we'll have our usual state, federal, HIT, and telehealth policy update. Mike McNeely from OAT is going to be here, the Office for the Advancement of Telehealth, and will be giving us updates on COVID-19, what's happening within OAT, and there's a lot going on right now, particularly with the Telehealth Resource Centers and various demonstration projects. And then the Federal Office of Rural Health Policy as well. And again, I should indicate that we are funded by the Federal Office of Rural Health Policy. The coalition is a part of TASC, our Technical Assistance and Services Center. So with that, then we're going to move into looking at infrastructure and broadband, getting an update on that. And then, as I indicated, we're going to have a panel discussion of quality and the effectiveness of telehealth. I think we're all pretty much in agreement that telehealth is expanding rapidly, that it's here to stay in a big way. But we think it's time to, let's take a look at what we know so far about how effective has telehealth been. Are there quality studies out there in terms of the safety, staff satisfaction, et cetera. And then we're generally always trying to build in at least 10 minutes so that you folks will have an opportunity to perhaps comment on a program that you're implementing, or to ask questions, or just bring up another topic so that, again, we can get the coalition involved in this discussion as well. So with that, very full agenda, I'm going to now turn things over to Neil, who's going to give us his update. Neil, you're on.
Yeah, thanks, Terry, for that. And Nicole, Andy, Mike, Bill England, others. I'll introduce a little more formally our two of our three guest speakers around that discussion of cost and quality effectiveness, Dr. Yale Harris and Dr. Elizabeth Krupinski a little later. But to start with, I want to very briefly kind of set that up a bit, because there's, kind of this ongoing yin and yang thing about the degree to which we continue to provide Medicare waivers and exemptions and eliminate the geographic site restrictions and include other providers in the continuation of telehealth versus a go slow approach, not go slow, but do more on the evaluation front in terms of effectiveness and quality and cost outcomes and that kind of thing. And a discussion that Dr. Krupinski and Drs. Harris and Terry and I had about 2 weeks ago led to us inviting them to be on a panel to just discuss where we're at in some of that, as Terry mentioned. But to start, let me just talk about very briefly, and we'll get you the paper on this as we usually do through Nicole after the fact, 5 leading bills around continuation of telehealth. The first is called the Permanency for Audio Only Telehealth Act, that would allow CMS to reimburse Medicare providers for certain audio only telehealth visits. The second is the Telehealth Response for E-Prescribing Addiction, the Therapy Services, or TREATS Act, isn't that clever? That was introduced in February by Senators Portman and Senator Whitehouse from Rhode Island. That would support the expansion of telehealth services for substance use disorder treatment, building upon the Trump administration's actions to waive regulatory restrictions for accessing care in the wake of COVID-19. It would make permanent key waivers, including the ability to provide medication-assisted therapies and other necessary drugs without the need for a prior in-person visit, and the ability to provide Medicare for audio-only telehealth services. The next is a little bigger in terms of scope, and that's the Telehealth Modernization Act, introduced in February by Senators Tim Scott from South Carolina, Brian Schatz of Hawaii, Jeanne Shaheen of New Hampshire, in an attempt to update coverage restrictions around the 61 million telehealth beneficiaries. And it would do two things: ensure that patients can access telehealth anywhere by permanently removing Medicare's geographic and originating site restrictions, and then also permanently include some of the otherwise restricted rural health provisions that were gotten over in the pandemic response bills. The fourth bill is the Expanded Telehealth Access Act, introduced on March 23rd, that would increase access to telehealth services by expanding the list of providers eligible for Medicare reimbursement. That was also done temporarily under COVID in an attempt to make available reimbursement eligibility for physical therapists, audiologists, occupational therapists, and speech language pathologists. And it allowed the Secretary of HHS to expand on that list. And the fifth is the CONNECT Act, which has been introduced several times. It would also do what the Expand Telehealth Access Act does, which is expand the number of providers, but then that much more, and is probably about the most comprehensive in terms of all of these bills. It gives HHS the authority to waive telehealth requirements related to payment for telehealth services, provided the quality care would not be adversely impacted. Waivers would need to be reassessed at least every 3 years to ensure quality. It removes the geographical requirements for telehealth. It expands the originating sites to include the home, which was done under the pandemic, allows for a waiver of telehealth requirements during public health emergencies as declared by the Secretary, allows for the use of telehealth services for hospice recertification. And importantly for this discussion today, I think a little bit, provides $3 million for audit, investigation, and other oversight activity relative to telehealth services, and a couple other things that I won't get into. On May 20th, as I mentioned, and this is right on point in terms of what Drs. Krupinski and Harris and Terry and I were discussing a couple of weeks ago, the General Accountability Office issued a 27-page report and provided testimony to the Senate Finance Committee around, what ought we do going forward before we permanently expand telehealth coverage for Medicare and Medicaid beyond the pandemic. And GAO expressed a lot of concern about the quality of services being, not concern about the quality of services, a concern about the lack of evidence about the quality of services, and suggested that the few studies that there are inconclusive, and said that they want more information on how telehealth has worked or not worked during the last year before making final recommendations in 4 areas. The first specifically is around spending, the second around program integrity, the third around patient health and safety, and the fourth around the topic which we talked a little bit about at our last call, which is a priority of this administration, which is equity of care and who's using it and who's not able to access it in rural communities and minority communities and disabled communities and that kind, and underserved populations. So that's consistent with the theme of the Department of Health and Human Services and the Biden administration around equity of care. Okay. On June 16th, the FDA called for a series of position papers in response to President Biden's May 12th executive order on improving the nation's cybersecurity. And FDA has been collaborating with NIST to establish new standards, tools, and best practices. NIST is hosting a virtual workshop in early June and calling for position papers to say, you know, what ought we be doing? I think there's nothing solid yet, but just the idea that the agencies are all responding to this right away means there's a lot more to become. And maybe, I think, is Bill England working on some of those issues for you guys? Or Mike or somebody might want to comment on some of that, or Layla or some of the other feds. On June 17th, and thanks Danny for sending this along just today. Had not heard this, he's always keeping us up to date. The NTIA issued an interactive broadband map that highlights the digital divide. And so you can see where broadband speeds fall below official targets, and also correlate those to high poverty and other areas. Look for specific locations, including tribal lands and minority serving institutions. And again, I think this supports the whole idea of equity in healthcare as we talk further about broadband and broadband distribution. And maybe John Windhausen wants to comment on that a little later also. It gives us the kind of situational awareness that I think we've been talking about on these calls for some years. And while Commerce, NTIA, and those agencies have been, I think, dancing around the edges of this, I think this is the most intensive effort yet on their part to help, help us identify what's going on. So with that, Terry, I will stop and let you introduce the next speakers, and then we'll get back to our panel. Thanks so much.
Sure. Are there questions for Neil, or does anybody else have a policy update that they'd want to share with us, or something about legislation? Also, if there's something of real value going on in your state, we'd really like to hear about that as well. So just see if anybody has any additions to Neil's report here.
Terry, this is Denny. Nebraska, we dedicated tax money, $20 million for the next 2 years each to increase broadband access. It started out just merely a cash giveaway, in my opinion, to telcos, but we got it tightened up. So there's some good guardrails, so to speak, on how that money will be distributed. So pretty exciting for us.
Yeah, which makes me wonder, Denny. I'm wondering if that I haven't had a chance really even to look at it since you sent it to me today. That if that NTIA mapping process is going to incorporate, resources also, that kind of thing, because in a GIS-like way, it could go way deep and identify, USDA money, Commerce money, HRSA money, state money, as and that would be really useful, right?
Yeah, I sent that map to the four legislators that were responsible for this legislation. So they got it right after I sent it to you today. So we will probably be in discussion next week.
Very good.
And Denny, I know that this is an issue that you've had a great deal of passion about, and so I know that you played a key role in Nebraska, just kind of driving this. So it's really good to see the state, coming up with dollars to help make this really important improvement.
Thank you.
Yeah. Anybody else? Okay, I'm going to turn things over now to Mike McNeely, who is from the Office for the Advancement of Telehealth. And he's going to give us a fairly comprehensive update on what's happening at both OAT and the Federal Office of Rural Health Policy, and anything else you'd like to report on. Mike?
Hey, Terry, thanks. Appreciate it. I'm going to talk about a couple of things going on in Oaks. Right now, we have a notice of funding opportunity for the telehealth technology enabled learning program that's open at the moment. It opened at the end of last month and closes on June 25th. Essentially, this program is specifically to connect specialists at academic medical centers with primary care providers in rural, frontier and underserved populations. And the idea here is that they will be providing evidence-based training and support to help them treat patients with complex medical conditions. A big thing about this is that we're looking at behavioral health on this, but we're also looking at the COVID long haulers in this, because we see that as a potential problem going at least longitudinally. So it will be one of several efforts that we do to try to address this going forward. It is Echo or Echo-like. We specifically went with learning collaboratives because there are a lot of different models out there. Echo is one of them, but we want to make sure that we have a broad swath. We expect to make 9 awards, and these are going to be somewhere in the $475 per year range for 5 years. The other program that we will be awarding is around August 1st. We should be announcing the TRCs. They were competitive this year, and a new period of performances should be opening up for the next 3 years. This was the first time the program was opened for profits. So we shortened the period of performance because we weren't sure what was going to happen, to be honest. So we wanted to make sure that we knew what we were getting into. But those awards should be released somewhere around August 1st and then starting September 1st. A few things going on throughout the rest of the office, and I will get on these because I have notes. The Rural Veterans Health Access Program, which is within the Hospital State Division, specifically the Wyoming Department of Health, in collaboration with the local VA, has established partnerships with 6 healthcare facilities statewide to serve telehealth as pilot sites, and developed a tool to evaluate processes and customer satisfaction with telehealth visits as at the pilot sites. The FORHP staff are currently working with all 6 sites and Wyoming Telehealth Network and VA contacts to implement telehealth services, provide technical assistance, and determine if any additional resources are needed by the pilot sites to initiate telehealth services. Elsewhere in FORHP, specifically within our Rural Strategic Initiatives Divisions, also known as RCOR, there are 2 new RCOR programs that will be awarded later this summer. Both have 9/1 starts. The RCOR implementation, which I believe is the 4th iteration of this, and they're going to try to award up to 78 awards. We're also doing I believe this is the 1st iteration of this, but the RCOR Psychostimulant Support Program, that will award up to 15 awards. It's a pilot that they'll be putting out. There is currently 1 open funding opportunity, the Rural Behavioral Health Workforce Centers, Northern Border Region. The applications are due at the end, June 28th, and they will be making 4 awards. Just as a caveat, because it's Northern Border Region, there's only 4 states that are technically eligible for this. And I believe it's New York, New Hampshire, who else is up there? Vermont, and I'm missing one. It may be Maine, I believe. And then, but the purpose of the program is to improve behavioral healthcare services in rural areas through educating and training health professionals and community members to care for individuals with behavioral health disorders, including SUD. Our core grantees are frequently sharing what they've been, that they engage with the TRCs. So we've actually been working with them on a number of projects, specifically as it relates to some of their psychostimulation and the behavioral health side of things. And then we've noticed a big jump in what's been happening within our core as it relates to telehealth utilization. It's doubled each year, it seems, just from usage. So it is something that is actively in play. Next, this one is going to be a little bit more detailed. I want to talk about our activities with rural health clinics in the COVID-19 programs. We have 3 programs within our FORHP, the RHC Vaccine Confidence Program, the RHC COVID-19 Testing Mitigation Program, and the RHC COVID-19 Vaccine Distribution Programs. The Confidence Program, RHCs will have exclusive access to $100 million in federal grant funds to address vaccine confidence. For the testing and mitigation, certified RHCs will receive up to $100,000 for COVID-19 testing and mitigation activities. And then for the vaccine distribution, RHCs will have direct access to COVID-19 vaccines from the federal stockpile. So for the confidence program, just a little, few extra things. With the $100 million invested, that's about 50,000 per RHCs. Organizations that operate multiple RHCs may apply for up to 50,000 per RHC. And this is the first federal grant program exclusively for rural health clinics. The confidence program, which period of performance starts July 1st and goes through June 30th of 22, is open currently. The application due date for the application is like June 23rd. HRSA will fund all eligible RHCs with complete and acceptable applications. The RHC CV program does not have any area location requirements. That's a biggie. So
Mike,
yeah.
Can I ask a quick question? Does that include the independent RHCs and the provider-based RHCs?
All certified RHCs.
Got it. Thank you.
And with me saying that, all they have to do is fill the application out. That's all.
Right.
If they get it in, they're going to get funded.
Okay.
One of the rare times I can say that's going to happen. So it is still open now. I just got a reviewer request for volunteers to review these things. It's all kind of all hands on decks kind of things within FORHP, but we expect a significant amount of interest. And then for the testing and mitigation, 460 million to over 4,600 RHCs. It's approximately 100,000 per clinic in one-time payments. And they started issuing funds, or will be issuing funds this month.
Hey, Mike, there was a question in the chat if there's a cutoff date for rural health clinics to apply for that.
For the second one that I talked about?
Yeah, I think the one where basically all they have to do is apply and they're getting it.
June 23rd.
Thank you.
So not too far off from now, but it is a very quick turnaround. There is some technical assistance available from NOSOR on that program specifically. So just if you need to reach out. Some other things that have popped up since I was sitting here and I wanted to share. ARC has put out a series of questions. The Agency for Healthcare Research and Quality has posted the proposed key questions for the systematic review on telehealth during COVID-19. They are available for comments on their Effective Healthcare website until July 8th. So it's something.
Sound is kind of fading in and out, Mike.
Sorry.
Yeah, just letting you know.
I appreciate it. Just repeat that ARC has some proposed key questions for the systematic review on telehealth during COVID-19, and they're available for review until July 8th on their Effective Healthcare website. And then one more. That is, and just, one last thing. One other opportunity, which is Bill's favorite topic, is NTIA as a funding opportunity that opened on June 3rd. It's specifically going towards tribal entities for broadband. It's about $1 billion investment. And and they're accepting applications currently through, I believe, September. And then a reminder, be on the lookout for money from USDA. They are working on a healthcare broadband program that is about a $500 million investment that should be coming out in the near future. Oh, do you have anything you want to add?
You're correct. It's September 1st, I think, is the cutoff for the broadband funds for tribal area from NTIA. No, I think you covered everything.
Yeah.
And if anyone has any questions, I'll be glad to take them.
There was a suggestion in the chat area that if you've got questions about the Rural Health Clinic funding, send them to Tammy Norville at NOSOR, and I think it's in the chat box, the email address. Yep. Thank you, Mike. That's a lot going on.
No problem.
We're going to move over to looking at infrastructure now, and as he does from time to time, John Winhouse is here, I believe, to give us an update on their initiative.
Actually, I'm not sure he is here unless he's on the phone. No, why don't we go ahead and move forward and I'll see if I can get a hold of John.
Okay, yeah, good enough. Well, let's then move into our main topic of the day, which is on the quality and effectiveness of telemedicine and telehealth. And I believe we're going to turn it over to my co-chair here, Neil Newberger, to introduce our panel. And again, we would really appreciate it if you folks have comments or questions that you chime in here and kind of be a part of this, what's going to be a relatively informal discussion. Neil?
Thank you. And so as mentioned before, and Mike just reiterated a little bit, a couple things have happened. One, there's that GAO report that poses questions around fiscal integrity and effectiveness and quality and cost and outcomes and things. And then ARC is seeking answers to questions about how effective the ramp up was during COVID. There have been reports by NCQA and HQA and a couple other organizations where they've had task forces and things kind of dancing around these issues. We reached out to them. They were unable to give us any speakers, but better than that, we have two of the nation's leading experts on these kinds of issues because they've spent years doing this sort of thing. And I've known them forever. So let me introduce Dr. Elizabeth Krupinski, who's the Vice Chair of Research for Department of Radiology and Imaging Sciences at Emory University School of Medicine in Atlanta. I know her, though, as a professor at the University of Arizona in the Departments of Radiology, Psychology, and Public Health, where she spent a long time heading up state and national efforts around interactive healthcare and telehealth. She was a former president of the American Telemedicine Association. She's got a really long bio here that I won't get into. Elizabeth, tell me if I've missed anything key here. But yeah, so she and I and Terry began this discussion, like I said, a couple of weeks ago. And we thought to also include Dr. Yale Harris, who's Vice President of Health at the American Institutes for Research here, who has over 20 years of experience leading efforts to improve quality and access to healthcare with a focus on underserved and medically vulnerable populations. We should make you, Yale, a permanent part of this group, given the focus of this group. She's a national expert on using HIT and operationalizing data tools to improve care coordination and enhance quality for at-risk populations. She spent 16 years in technical and leadership roles at DHS, including as Director of Quality in the Office of the Assistant Secretary, Director of Health IT. She was at CMMS and at the National Coordinator for HIT ONC. Yale, did you have trouble holding down a job while you were at the department?
I joke that I missed FDA, SAMHSA, and NIH.
Did I? Oh, okay.
I have to go back
So-
at some point and make sure I've checked every box.
All right. Well, so lots of government experience here and academic and research experience between our two speakers. So why don't we get into, why don't you just give us briefly, and Yale, tell us more about, you know, kind of what you're doing now in terms of the research, and Elizabeth, you too, and then we'll fire some prearranged questions, but hope that everybody on this call preempts me and Terry and asks you questions. Okay, so yeah, why don't you take it away for a few minutes?
I don't want to step over Elizabeth.
No, go ahead.
Okay.
You're good.
It's a privilege to be speaking with you, Elizabeth.
Same
So
here.
I have been, first of all, I'm no longer with the American Institute for Research. I actually have launched a small business called Laurel Health Advisors, and we're specifically focused on using technology to improve access and quality for underserved populations and reducing health disparities. One of the projects that we are working on right now is a project with CTEL, the Center for Telehealth and eHealth Law, where we are collecting data from health systems across the United States. We currently have about 1 million encounters, including all encounters from Medicaid in one state. And we are collecting data from several other health systems. So our goal is to have between 2 and 3 million telehealth encounters by the end of this month. And they represent a wide array of services. So we made sure we got dental, nutrition, physical and occupational therapy. We're really trying to make sure we have a broad spectrum of how telehealth was used during the pandemic. And what we're doing is developing a cost-effective analysis model so that we can demonstrate the impact of telehealth had it not been available, what the costs would have been. And we're going to use a simulation model to detect those costs. We also have data from many of these systems pre-pandemic. So we can look at how telehealth use has evolved and changed. We can do analyses by payers type. We have every single payer, including self-pay, private pay, Medicare fee-for-service, Medicare Advantage, and Medicaid. So really will allow us to do a robust analysis of issues related to health disparities. We are asking for the first 3 zip code, just everyone's zip code, so we can also look at which areas were serviced, what types of services were provided. So this is really going to be able to give us a picture. And we presented last Friday to the White House Economic and Domestic Policy Council and shared these results with them. And they're very interested in getting an update this summer on where things stand. So our goal in the short term is really to do a high-level cost-benefit analysis and effectiveness modeling of the telehealth in the absence of care during the pandemic, but look over time to compare pre-pandemic data and really demonstrate that telehealth is a feasible, viable, and effective, cost-effective, and high-quality method to provide care and look at individual issues. Thus far, our initial analysis has shown that there's a lot of issues related to use of telehealth for behavioral health, of course, but medical malnutrition aligned with telehealth. So that's a big issue. And another big issue that we've identified is the use of telehealth in rural areas for sexual assault diagnostics. So some interesting preliminary findings. That's what we hope to do after we get the report to White House and Congress.
And my apologies, Yale. I'm finishing a week of 80 relatives in town for my daughter's wedding, and I turned 65. The 65 part is why I can't remember that you told me all about this in our call, and I'm just your moment about your change to Laurel. And that is what we wanted to talk to you about. really great. And we want to talk about how you come about that data and that kind of thing, and who you work with, and how you get something like that going, and what are the broader implications. Dr. Krupinski, when you and I and Terry talked, we surfaced the idea of kind of what works, what doesn't, and under what circumstances, to which you interestingly said, well, we know at least something about what works and less so about what doesn't work. Maybe you want to start off around kind of those issues and what you're working on now also. Thanks again.
Yeah, no, thanks. And again, thanks for the invite to do this, and a pleasure, Yael, to work with you as well on this. I thought it was funny when you started out and you were talking about the GAO report that, it basically pointed to research and stuff over the past year. Like all of a sudden, telemedicine is new. This is all brand new research and findings, ignoring the fact that there's some 30 years worth of research out there that is a lot more concrete and less mixed than people know of. And, so I think we do know a lot. Again, we have practically 30 years worth of research on telemedicine, its effectiveness, limitations, and so on. Admittedly, the early years were more feasibility, a lot of satisfaction and stuff. But in the past, I would say 15 years, we have seen just awesome, highly reliable and valid, randomized clinical trials and all sorts of great studies that are out there. So again, I find it interesting that sometimes, these reports come out as if, boy, all of a sudden telemedicine just sprung up out of the head of Venus for some reason because of the crisis. Well, it didn't. It's been around far much longer than that. I think in terms of the limitations, I think what we learned, if you think about, a lot of telemedicine, admittedly, even though it's been around for a while and used in a whole variety of situations, a lot of it, and especially a lot of the studies, have come out of academic medical centers and large clinical practices, hospital systems, enterprise-wide, and so on. And practices there are very different than a lot of the places that had to adapt to telemedicine during the crisis, the FQHCs, the RHCs, the CHCs, the clinics, the private practitioners. And that's where we didn't have a lot of data on, prior to this, simply because these people are not involved in research. So any studies that were done were probably using, large conglomerate data and not really going into these different types of practices. And when you get people who all of a sudden have to suddenly ramp up and do something new, yeah, we are going to experience some mixed results. It does not surprise me at all that some of the stuff coming out is saying, it worked and it didn't work. Well, if you're not prepared for something, and overnight, literally, you've got to change the way you practice without training in many circumstances, of course, you're going to find things that didn't work. So I think some of the limitations that we're finding are because all of a sudden we've got a broader range of providers engaged in telemedicine, trying to do almost everything that they used to do in person by telemedicine, where a lot of what's been done to date has been, like I said, in these large centers with, very set, sometimes advanced practices, where you go in, you carefully take the time, you put the money into it, and so on. And so the limitations are, in my opinion, sort of, we ran up against the wall of real life. And all of a sudden it wasn't, let's have our telemedicine clinic on a Thursday afternoon and let's carefully do all this. It's like, wham, here, do it. And you've got to do everything. And that is the type of stuff I think that we need to publish, is to reach out to some of these practices that have never really contributed to the literature before, and really get down into the trenches and say, okay, the little things that you do when you're in the clinic with the patient, did they work?
Yeah.
And it's beyond just, can you do the physical exam? Can you use your iPhone to do X? It's more kind of fuzzy than that, I think, in terms of the limitations that we're learning about.
Yeah, hindsight is great, and here's a Captain Obvious statement, but I guess that all of the advocates, many of whom are some of us and ATA and all the groups, should have, during those pandemic bills, thought more about this and had a few million, which would have been a drop in the bucket, set aside for organizations like you and Yale and the research organizations at ARHQ and CMMI and PCORI and others to do this, right?
Yeah.
So,
Dr.
Can't go back in time.
One of the issues that comes up is the whole issue of privacy of information, and that there's concern out there that somehow telehealth is going to expose our medical records to being hacked, et cetera. So would you please comment on what you see as patient safety or patient record safety issues here, and whether telehealth in fact maybe endangers that patient safety concerns?
I mean, I'll start and then Yale can jump in. I mean, I don't see what the difference is, perfectly honest, being seen somebody hacking a telemedicine record versus an electronic health record. What is the difference? I just don't get what people think is going to happen during a telemedicine visit that is not already happened any gajillion number of times with existing records. I mean, how many HIPAA violations existed that have nothing to do with telemedicine? That's the comparison I would like to see somebody do, because I can guarantee you that the in-person existing non-telemedicine HIPAA violations far outweigh anything that has happened with telemedicine to date. And so, like I said, I just personally, I don't get what the concern is that all of a sudden telemedicine is something that somebody wants to hack into.
Can I add that it is actually contributing, though, to a digital divide? So, everyone's talking about how now everyone's aware that these health disparities that, of course, never existed before the pandemic, and all of a sudden people are commenting that, and then they're saying telehealth could exacerbate that. So I've been doing a lot of research on that to try to counter that argument. I will tell you, if you look at Seema Verna's article that was in Health Affairs blog, it was preliminary data on Medicare. It's the only real comprehensive data we have on Medicare fee-for-service. They found no differences by race and ethnicity. She did not report by age. And we do know there's a digital divide because of technology savviness. There's also a digital divide in terms of fear of technology. And so that's where, we have that. They don't, the EHR, they're like, I don't want my data in the EHR, but it's seamless. It's not, they're not as aware of it versus having a telehealth visit. First of all, accessing the telehealth visit is a challenge if you, don't know how to use technology, or you don't have a tablet, et cetera. But then second of all, they feel like this video is being recorded and suddenly it just exacerbates those technology fears. So it's really an issue we need to address if we don't want to create further health disparities between the older adults and the millennial generation.
And it's the millennials who are actually doing the recording as patients of these sessions and putting them out there on YouTube. It's not the providers and it's not hackers.
Exactly.
I mean,
so my experience in Nebraska, and that I'd like to see more research on, and this happened a number of years ago. I happened to be in a hospital where a mental telehealth consult took place. And I happened to be there as the door opened and this patient came out, and I said, how are you? Because I didn't know if she was there for med or for behavioral health. And she said, well, I'm doing much better. Thank you for asking. I just had a mental health consult. And I said, well, you liked it? And she said, I loved it. This is fantastic. And I said, well, why did you like it? And she said, because I felt in control. In the past, I was actually abused by a provider in person, and now I have control. So I think the research that needs to be done is beyond the simple patient satisfaction to what is it that patients are actually gaining from this, and what would they like to see? We spend too much time up here in academia and in policy setting, et cetera, and we need to ask the on the ground question, how is this helping you? That is our most powerful argument, in my opinion.
And Denny, with behavioral health, that is one of the most essential things. We really need to publish all of the advocates for continuing, for example, medication-assisted therapy and opioid use disorder counseling have shown that patients feel less stigmatized when they can access care by telehealth. We just haven't done enough scientific research to actually publish the impact of that on patients dropping out of care or patients, I've heard anecdotes of fewer missed care appointments, an 85% increase from one clinic in terms of medication management visits that were formerly 50% no-show rate. I want to see those things published so that it's not just people going to Congress and testifying. It's actually scientific evidence that telebehavioral health is a panacea for people who had either concerns, just like the one you presented, difficulty accessing the care, or just didn't feel comfortable going into a clinic to receive that care.
It's especially true in rural areas because your pickup is known if you pull up in front of a mental health facility.
I'm thinking also to follow up a little bit on Dr. Kropinski's comment about HIPAA violations or the non-existence of HIPAA or near non-existence of HIPAA violations. Maybe we ought to diffuse the whole notion and, in the public's mind about that, but also about the whole fraud versus issue. There is telefraud and the Justice Department's all over it. And companies that hold themselves out to be doing telemedicine, but it's BS, right? From overseas and everything, but that's fraud. And it's different than, cost overruns, uploading, versus right coding, getting it all wrong, that kind of thing, which we very much need to look at in terms of effectiveness, in the comparisons of that versus in-person visits. But maybe there's some things we can say near term based on all of this to put the field in a little better position in the minds of people.
And since we're on the topic, let's ask that broader question. What type of studies and what type of research do we need to actually measure the quality of telemedicine and telehealth? I think we've heard a little bit so far, but let me just throw that question out to the panel. What else do we need? By the way, I should comment, Dr. Marcia Ward from the University of Iowa is on, another evaluation research expert here too. So Dr. Ward, I'd invite you to jump in on this if you have a comment or perspective as well. But let's just throw that whole thing out to the panel. What other studies do we need if we're going to provide the assurances that may be necessary?
I think I already said that we need to extend it to different types of practices as well as multi-practices. But I think, longitudinal studies, and when I say longitudinal, I mean really, I don't mean 3 months, I don't mean 6 months, I mean a year. 2 years. I read studies where they do a 3-month study on telediabetes education of patients, hoping that they're going to transform their lives. There is so much evidence we have that through traditional diabetes education, it's incredibly difficult with this chronic population. So why all of a sudden is telemedicine in a 3-month trial going to make it all better? It's not. We need true longitudinal studies with patients to truly look at sort of the ups and downs and the fluctuations. And, maybe it takes 6 months to get somebody to come and finish all of their diabetes sessions that they're supposed to finish. And I think to truly put theory behind a lot of the studies, so implementation sciences, health services research, there's simply not enough being done in those areas in telemedicine.
Terry, one thing that I played a minor part in, I guess, about 4 or 5 years ago, I was on the Senate Aging Committee panel on telehealth and Senators Nelson and Thune. And afterwards, the staff asked me on the members' behalf, so what, Neil, what should we do next, blah, 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 in terms of, evaluation, that kind of thing. And suggested, and ARC went ahead, or ARC went ahead, Dr. White went ahead and put up money because I saw him the next day at one of my telehealth briefs for Oregon Health Sciences University, Dr. Bill Hirsch, to do a metadata study, a study of studies, which looked at like the then 15, I can't remember how many, 1,500 or 1,700 peer-reviewed published studies in telehealth there were that they could find to date. And I'm wondering if that kind of thing needs to be updated also so that we can crosswalk and correlate among all of these hopefully, you know, a lot of different efforts looking at all this kind of thing. Just
Oh, I think that's absolutely what we need. And we're at the point, like I said, we got over 30 years worth of data. In the beginning, we couldn't do it, but we're at the point where there's enough studies where you could get a true meta-analysis out there and get some really valid and reliable results.
So
And there
CTEL
are things
funded,
out there.
I'm sorry, Elizabeth.
No, I was going to say there are increasingly a number of those meta-analyses being published.
Right, CTEL, the Center for Telehealth and E-Health Law, funded a study by Mercer University to look at all of the published research on the cost impact of telehealth. And basically what they found out of thousands of studies was they either weren't rigorous enough or they couldn't be generalizable. And that makes sense. You're looking at different populations, you're looking at different telehealth modalities, ways of delivering care. There were just so many variables. So we need to publish it, but my husband and I put together a telehealth data dictionary, which is a way to basically standardize data from telehealth data and put it in a standardized format so you can compare across programs. And so that's what we're trying to do. And actually, Elizabeth, I just told my husband he better get the manuscript to you soon for the next journal, but hasn't gotten there yet. But I think that the point is that we need to do that, but we also need to make sure that what we do is generalizable, because when we do a meta-analysis of all these different studies, we cannot draw conclusions from them. But with the use of the Telehealth Data Dictionary, I think people could actually do those meta-analyses, ask, especially with current data, ask them to submit the data in a standardized format or convert the data to a standardized format. And then you can generalize. And we have enough studies now, enough cases now that you don't have to worry about, you only have 10 services by a physician assistant in this area and only, 10 oncological related telehealth services in this area. You now can have enough cases that you can really draw conclusions based on service type.
so go ahead. Yeah, Terry, go.
Well, my concern is that information is not getting in an understandable way to the average citizen. We use jargon all the time and we use academic terms all the time, but how do I, Denny Behrens living in Nebraska, fully understand the research that's being done using terminology that I can understand? I don't really want a dictionary. I just want somebody to take this and put it into language that I can understand and I can share with my neighbors. We do a terrible job with our research of getting information out that is easily digestible because we all have our separate languages and code. So that would be tremendous help in my opinion.
Absolutely. And Denny, the dictionary was a method. It wasn't planned to, it is, very academic, but the point is that we have all this research out there and we can't generalize. So if someone did a meta-analysis of all the research and put it out there, could you really draw conclusions from all of these different ways the data was collected? How do we standardize how we collect, how we analyze that data? And so that was the point, was how to standardize the data collection so that the analysis can then be written for a lay audience and stated in meaningful terms versus all the caveats that researchers need to put on their research when the data is collected different ways.
And as you talk about this, what I could foresee, and for any of those who are with funding agencies, this might be a good RFP, is in the AI world, there's a ton of these grants and stuff that are being issued to compile databases for AI cross institutions. Here, submit your images, de-identify, ship them up. Here's the standard format. That's exactly what I think Yale's proposing, if you take it a step further, which is, okay, let's get somebody to be the curators of a database where everybody in the United States who's doing telemedicine and elsewhere, if we want to go that far, upload data in some sort of standardized data format using definitions that then researchers could then access, sort of like the Truven database or the SEER. Look at all these other databases that are out there. That would be a huge, and we can collect all sorts of different variables, but yeah, get at some of those cost issues, and people could do any sort of cost modeling they want. But the fact is you've got standardized data.
All right, so
multiple sources.
Let's
Can I just jump in here?
Yeah, please, Lois.
Sorry,
Lois, go.
thank you.
Yeah,
I just wanted to comment on a couple of things. One is Yale's conversation about health disparities and the generational issues. And during COVID, we saw more audio telehealth, which was never considered telehealth before. And that has really helped people with, who couldn't use the technology for a variety of reasons, right? Maybe arthritis, maybe age, things like that. And now we don't know whether that audio reimbursement is going to go away or not. And I think having a separate analysis of the audio component and its implications of the health disparities, I think is an issue. And my other comment was back to Elizabeth's comment of, I'm doing interviews. I just finished about 60 interviews with FQHCs that started telehealth during the pandemic, and that it's really unfair, like you were saying, to compare them. They couldn't get equipment. Now they had primary care docs doing this. I mean, it was, they had their own, they had staff. They were trying to get, some of them hundreds of staff working at home at the same time of doing telehealth. So I think that's really a whole nother bucket of research and considerations that if it's mixed in and aggregated, it's going to really impact the quality and the accuracy of the data. So I just want to throw that out there. Thank you.
Yeah.
Good point.
Thank you, Lois. Does anybody else have a question or comment? We probably should just pause periodically to let people jump in here. Thank you for that, though, Lois. Anybody else?
Harry, this is Matt McCullough. I had a
Matt.
question on, I had a specific question on quality metrics. So in Utah, we have an all payer claims database, and we're working with the Department of Health to pull a monthly data feed on comparing volume of claims for telehealth and in-person visits. But we're really interested in looking at cost and quality outcomes. And what we're trying to figure out is what can we pull from a database like this to help us show the impact on quality. So we're looking at specific measures like, readmission rates. When a hospital started to do more follow-up visits using telehealth, did readmission rates decrease? Did antibiotic prescriptions decrease? Can you give us any other ideas? What measures exist or can we find to really look at quality outcomes?
So Matt, are you aware of the NQF quality framework?
No.
So the National Quality Forum and Marcia Ward was and is, because there's a second one now, co-chair of this, but it developed a framework and that's now being revisited specifically for rural communities on how to measure the impact of telehealth. So since Marcia's here, let me turn over to you, Marcia, so you can explain some of the main themes of the areas that should be measured.
Actually, I was going to go in a different direction, and that was a great segue. But to be really practical, Matt, what we've used in a hospital setting is CMS measures, because the small hospitals, they're very well defined. They know what those measures are. Things like in the emergency department, for a patient that presents with stroke symptoms, where the diagnostic's done. And we were able to collect data because of HRSA funding off of 6 networks that were implementing some sort of a telehealth and an ED, and able to pool that data and publish it. And so I always think of what's practical and at hand already in these hospitals, and especially the CMS measures are so clearly defined. They're so experienced with what the numerator, denominator, eligibility, all of that is. And that is quality measures in terms, often process, but every once in a while, some of it is outcome measures that you can get, like you mentioned, readmissions. And so that might be a good place, practical place to start.
Marcia, did you have any other comments that you wanted to make?
So, so Yale mentioned, so NQF, hopefully people are aware of NQF measures, and NQF, National Quality Forum, goes through such an incredible process when measures are nominated by different societies and they review them and collect the evidence and all of that. And then they endorse certain ones. And it really is such a hugely extensive process. We have looked at those and are currently, because there is an NQF work group right now that's trying to look at telehealth and health system readiness. So the whole pandemic, pulls into this, the pandemic experience. There are no existing NQF endorsed measures for health system readiness. There are some that would be applicable in terms of telehealth, because telehealth covers all of medicine. So we're trying to find that sweet spot. And as Yael mentioned, we're trying to come up with a framework that identifies what are the domains like cost and like provider satisfaction and system communications and things like that. So we will be coming up with a framework that'll come out next fall, published by NQF on that. And what Yael was talking about 4 years ago, and Yael and I were on this committee, we did come out with a framework for telehealth. And it does have major domains of patient satisfaction, provider satisfaction, cost, clinical effectiveness, and access as major domains, and suggests those domains being important for the measurement of telehealth, and suggests a few telehealth NQF endorsed measures that would be appropriate for telehealth. So it's a good beginning point.
Marcia, is that fall of this year, 2021, or are you looking at 22?
It should be available in the fall of 2021.
Terrific. Boy, that's needed. Terrific.
Yes.
Talking about that topic for anyone here in our panel, what has been what you're looking at in terms of patient satisfaction? So that's Denny's concern at both understanding telehealth and the options here. But what sort of satisfaction have we seen to date?
One, if the technology works, pretty much everybody's happy, to be perfectly honest. And speaking as someone who's on the editorial board of 3 major telehealth journals, if I have to review and reject another article that simply looks at satisfaction, I'll go crazy. We don't need more data on patient and provider satisfaction. We need, as Yael said, something more in depth. We need to know about, how do they feel about the sessions? What do they get out of it? What did they not get out of it? Just not, are you happy and did it work?
Elizabeth, I think that's an entirely satisfactory answer.
And one of the big areas is experience. One of the measures that we're looking at for another project I'm on is how many encounters was there technological barriers? Was it cut off, or were there challenges? And how does that affect patient and provider? Because when you have when you ask the patient provider, are you satisfied? We don't delve into the reasons they weren't satisfied often. We just do a scale. And technology barriers are the #1 reason people are dissatisfied, and it affects and reflects how they will use telehealth in the future. If a provider had a bad experience, he or she is less likely to use telehealth in the future. And if a patient comes to them and they're like, no, it's better to do this in person, of course, the patient's not going to use telehealth.
I'd love to see some research on effective ways of preparing for the visit, and so that it prevents the technology problems, because in these interviews, I found some places they just default to the telephone, right? Because it's going to be a smoother visit rather than, and that the preparing the patient for the visit, making sure the technology works, is extremely time consuming. And when you take these small FQHCs or rural hospitals, they just don't have the bandwidth to spend 20 minutes on the phone, and the patients don't have the time either. They have busy lives too. So it would be good to see some some research on effective ways of patient preparation in terms of the technology that's efficient and effective.
There's also a lot of great videos that have been put together that anybody can go download and refer their patients to. And Michelle from HRSA just sent out this morning a link to a whole set that was created in like 6 or 7 different languages. You know, how to tell your patient about telehealth, what it's about and what they need to know. So there's ways that you could build research around, you know, we provided this video or we didn't.
Terry, I've got a hypothetical for Elizabeth, Yale, Marcia, or anybody. Okay, pretend that the labor age appropriations bill for FY 2022 is under consideration right now. We don't have to pretend that. And members are interested in evaluative kinds of things. And the language in the report's would say something like, of the funds appropriated under this act, X million shall be made available to what agency to conduct research around what topic. And your choices of agency are, or maybe all of them, AHRQ, PCORI, CMMS, CMI, DOD, ONC, ORHP, or others. And how should that work? And who might coordinate? You're on the outside looking in now, so you can feel free. Who should be doing this in the government?
All of the above.
Okay.
Yeah, I was gonna say, from my
All
perspective, the
about
most
millions of
effective is when you
dollars.
bring the money together and you jointly work together. It's better for dissemination. It brings different perspectives. Although, you know, my colleagues who are in the federal government will understand that getting an agreement, a memorandum of understanding could take a year in and of itself, but it is far more effective in the long term because you bring these different expertise to the table, these different perspectives. And ultimately, I think it's what Denny said, how do you get it out there? You could do the greatest research and not get it out there. Well, all these agencies work with different populations. It's a much better way to disseminate the findings.
Maybe OSTP or something, Office of Technology, Science, you know, whatever.
Mhm.
Would that coalition approach be viable? Is it possible? I totally agree. That seems to make the most sense here, but can we get intergovernment cooperation? Any possibility in that regard?
Absolutely. So when for those of you who remember the Text for Baby program, that was a perfect example where HRSA led the evaluation, but we worked with ARC, CMS, ACF didn't exist, but its predecessor. And what we did was it took forever to get, you know, even it was like they gave us $10,000, it took forever for the paperwork. But the fact that all of them came to the table with any resources whatsoever meant they were invested in the project. There was a steering committee and a board that advised on the intervention, on the evaluation. And I think ultimately, you know, while things move slower, it made it far more effective. And the reason you've all heard of Text for Baby, besides the fact that Voxy was very good at advertising it, was because it was cross-federally invested to look at its effectiveness.
As an illustration of that, we have touched on a little bit the whole broadband issue, and you're aware there's billions and billions of dollars going out in broadband right now through multiple federal agencies. And in the Consolidated Appropriations Act, there was a mandate to for these agencies to work together and coordinate, so we're not building broadband on top of broadband. And I can't go into detail, but I can say for sure all the agencies are talking, and it is working.
Good. And maybe at the Office of Science Technology policy within the White House or somebody could serve in that role, you know, if the field across all its iterations and everything were to bring that up and get them interested.
Well, let's see if the rest of our coalition members have a question or a comment. Just want to open up the floor again to other folks. If you have an update on something, these last few minutes we're together, give you that opportunity.
Terry, can I ask one last quick question?
Absolutely.
I've been dying to ask this question, and I feel like we have the right group to help answer it. It relates to both patient satisfaction and cost, but there's all these cost savings on the patient's end with a telehealth visit, you know, reduce time off work and reduce travel and all these other things. How do we account for those cost savings? And should we, when we're telling the story of cost savings in telehealth?
I say absolutely. And there are studies in the literature that have looked at that and tried to collect the data and build cost models around that. So it has been thought of before, but I think absolutely it has to be included.
And there's ways to present it. It's cost offset of healthcare services. So you're looking at, did we invest in the technology, we invest in training our staff? How did that affect, hospitalizations, et cetera? So the actual, economic hardcore, but then you want to look at, as you said, from patient's perspective, travel time, the convenience factor that they would have had to miss work or get childcare. One of the studies I was doing, I did on behalf of HRSA years ago when was a study on rural tele-ED care. And we looked at, transportation time, and we were looking at costs in 3 days. One is looking at how long they'd have to travel by car and the gas mileage, or how long they'd, which is not just mileage, you have to look at how to get there. But the other one was if it's really an emergency, medevac is necessary, and how much does that cost? So we were trying to figure out and model all of those as obviously, what we put forward was a suggestion on measures to be used. They weren't endorsed measures, but basically thinking through all these factors that you can't just measure the patient's time, because you have to affect how it affects the, what do they make per hour that they're missing work? How much is it costing them? Are they having to take public transportation? All of these features that we normally overlook need to be taken into that calculation, because in the end, that really does affect whether they're going to seek the care, which then affects whether you achieve the health outcomes you want to achieve.
And these are
And can I
particularly
just-
important.
Oh, go ahead.
Yeah, just quick comment here. These are particularly important calculations for value-based models, payment models in that regard, because as you're saying, Yale, that might have been $60,000 for that air transport. And in essence, the accountable care organizations, for example, are able to calculate that cost and should have every motivation to try to figure out, what sort of savings are we experiencing here. But as you're saying, or as we're saying, that's not calculating in all the lost time from work, all of the convenience that it's providing to the patients. And I think, this is a huge factor in rural America, way more than it is in the bigger cities. It's like, if you've got to take half a day off to go to your doctor, if you're in the middle of the night and it's going to take you 2.5 hours to get to the clinic and back, that's a substantial amount of time. So I think in rural, this issue is extremely important. There's a lot of savings here over and above what it's saving the payers.
This issue is important for the patient, and in rural areas, there are a lot of publications showing this, calculating this, a lot of evidence supporting it. But I think we all have to remember that what CMS cares about is what's going to affect their budget. And that's where they're crying for the evidence beyond avoiding travel and time off work and all of that.
Can I just add something in here is, I've seen a lot of those research papers on that cost, but one of the costs that's often not factored in is the cost of not delaying care. So if someone puts off going to see a doctor until something is more advanced, and that's something that CMS would care about, right? If someone is getting their care in a more timely manner versus delaying care. And I have not seen, when they're looking in these cost factors, that incorporated. And that's a big factor. If someone, puts off, getting treatment for something and it becomes a much more exacerbated, expensive problem, something like, diabetic retinopathy or something like that, that if it was detected earlier, it could have been a lot less expensive. So the cost savings of delaying care is something that is often overlooked, in my
But
opinion.
we may be
Unless I
able to
just missed it.
actually get that now because a ton of patients did delay care during COVID. Some of them did go in and see, and some of them did do telemedicine. So there actually may be data out there now if it could be accessed properly to look exactly at that topic.
Folks, we have run out of time. This has been a terrific conversation. I've learned a lot. Thank you, especially to everybody who's participated, but Dr. Koprinski and Dr. Harris, we really appreciate you being here today. This conversation will continue, obviously, in our future coalition meetings, but with that, we're going to wrap things up. Nicole, any final instructions here before we leave?
Nope, not that I can think of. Great conversation.
Okay. Yeah, thanks so much, everyone.
Thank you, everybody.
See you next time.
Thanks.